So there's like layer to know what is palliative care? Palliative care definition or so we derive from the Latin word pallium. So it's like a cloth. Cloth means covering, so basically relief of suffering, but the indirect bala piamis, the Tanzania Hario for the ball, pallium alarabo. The general definition of biomedicine, palliative care is an active total care of patients whose diseases are not responsive to curative treatment. So that's why generally, of course, patient can be cured, diseases can be cured. Go ahead and cure it. That general usually everybody is focusing on cure. Another concept generally 90th century model. This is the actual principle of medical care in 90th century and 18th century. Actually, cure you cannot cure most of the diseases like tuberculosis, right? So the infection is. So the other option to cure sometimes if you can, but but you can relieve often, but also comfort always. So that palliative care, who can actually get that? The 20th century, we focus too much on the cure. So everybody is looking for cure. So patient asks, what is the latest treatment? Latest, can you cure it? So the paradigm was shifted. The palliative care, we cannot cure a lot of diseases. Even the coronary artery disease, we cannot cure it actually. The angioplasty or the even bypass surgery, you're not actually curing the diseases. You are trying to relieve the obstruction and to prevent the total obstruction. You cannot cure coronary artery disease. You cannot cure cancer still, right? So medical student did heart failure. That was back in 1986, 7. Heart disease, patient heart failure. They die in 2 years. Because I don't have to aspirin payment, nitroglycerin payment, Lasix, diuretics. That's it. I don't inhibit right? So if you have a diagnosis of heart failure, 50% died in 2 years, period. So people can die because you have a transplant, you have an angioplasty, but they suffer more because they can't just die. So they suffer for a long period with a shortness of breath. So that's why generally we have to think about how do we comfort and how do we relieve often. So palliative care actually addresses the whole person. It's not just a disease. You are trying to fight with the diseases. Sometimes we are missing the whole picture. We are treating the whole person. That palliative care concept try to address the whole person, not just the diseases and diagnosis and treatment. So of course the physical symptoms. This is the bread and butter of palliative care. You have to do your due diligence, which is controlling the physical symptoms, and also functional decline. We need to think about the physical therapy exercises, right? So then, what about social? Loss of friends, loss of roles, loss of job. That is what the palliative care addresses. The emotional. Psychological distress like depression, anxiety, fear of unknown, because I don't know how long I'm going to live, right? So that psychological problem, coping and fear, right? I'm fear of pain, I'm fear of dying alone. So spiritual, again, the meaning of life in the did I make a good life? So how did I treat my family, my friends? So of course, even you can also grieve before you die and about the family. So palliative care addresses the grief and bereavement for the whole family. So develop the environment, disease and prognosis, patient prognosis or explain life activities, transportation, preparation for the end. Closure. People need to prepare for the closure. Even talking about death and funeral plan. Of course, nobody wants to talk about funeral plans, but this is a reality. You need to plan ahead. So palliative care address the whole person. It's not just diseases and treatment. So most important thing, medical student we didn't get this training. Even residency program we didn't get this kind of training. The palliative care study low bureau, the follow I realized this is how we should communicate those serious news. right? So there are steps. So the systematic approach for the delivering serious news can, foster collaboration among the patient, the family, the clinician. So this is important. You are pressed for time. You are busy. A lot of patients to see. This is all, palliative care will, integrate so, you need to do it properly. So number one, prepare for the meeting. Who is important, right? So decision maker. Ask the patient, the decision making. A lot of time, patient may say, oh, I don't want to make the decision. I need my son to know the third, some fine, make sure, the patient, important, person in their life, will be able to attend. Even meeting the patient, what do they know? Sometimes they overheard from the nurses, right? Or overheard from another, like, the house, the house surgeon. So just to make sure, what do they, understand first before, we deliver the news. So, to me, the Google, the direction, the driving direction, where we are at, where are we now, and where do we want to take the patient to? So the patient understanding, we need to understand first. Now, what very important, you got to ask the patient. Your diagnosis, we have a diagnosis, yoga, treatment, this solution, but still patient, they have the right to, define. The cancer, so pure one, it's not done with pure one. So, the patient, that's fine. As long as the patient that I don't want to, if there's a bad news, it is about cancer. I don't want to talk about it. I don't want to know. So why don't you just, done with pure one? That's fine. So the patient, family, don't want now to deliver the news for we have, that's another slide. How do we deliver the news? It's not that's it. Okay, now the diagnosis are the COVID infection, the cancer, that's not the end. Our responsibility to make sure we respond to the feelings and emotion. But say we have to sometimes spell out. The what community don't know what it just to check with the emotion. Now to organize a plan. So what's the next step, right? Now to create, now to the CAT scan low on me, follow up X-ray low on me, area, plan low on. So how do we tell the patient? So now we deliver information in the sensitive, straightforward manner. It's a serious, news for no. So the medical term through now and your infection, infection, cancer, so like cancer, stomach, cancer, the 𝐤𝐞𝐬𝐤𝐿, 𝐤𝐞𝐜𝐬𝐿, cancer cell do it, so the step by step, so make sure they understand, because sometimes they are overwhelmed, they cannot hear. First, cancer they cannot absorb, everything, everything froze. They cannot absorb, they cannot take it. So you may have to pause it, right? And also make sure they, they understand. Oh, they want to continue. That's fine. So we may have to schedule another meeting. Very important. One in shop, not for building now. Result out of Piana, we damage general Tindru, the income of hope. So the income of Usoria, the Renal, one debate the ball. Instead of, oh, generally, cascam, cancer tree, this is a very shocking. So just one in shop, the result out of, Piana, we damage general Tindru, the income of hope, general hope, so has through knowledge, that's why not the inso. As so even you can check it. Okay, the hope, tap So they have the right to say, they come home with knowledge, some charge, do not done ever set your. That's still okay. No, so the the delivering the the news one, the systematic approach alone, not on knowledge plus through machine machine maybe that delivering bad news. How to quite the okay now to be the symptoms of jump your message. Patient goals of there goals are valid. The way now that with the way now like that show up your now say the manager way now she people they are not statement. That's fine. The doubt it the man they are not a lot of good actually this is the best pain relief they are alone so more. On the other hand, even the man to get now like I know. I can't giant the Belauti, the Behaka say, the CPM, the opioids or the morphine or below Yamesra. Sorry, I do pure happy Roma, through Betchinti, but from a can I know in pure I had no CPM, so you're sorry, I don't know, understand him, 3 year cool, no. Assess the patient functional state. This is something the functional patient, I will learn it new so the online pain control because because how in the one and the Korean and ham you are pain control bill be now look in the Madonna through dignity one go to one serious thing clean up through all very embarrassed. Hey, no determine you are pain or cancer. The pain threshold so they and we should encourage you say oh well-being through the even better pain control patient who are moving we should encourage we need to know. Assess the patient's physical ability to tolerate different treatment modalities and routes of medication administration through and the 𝐤𝐞𝐬𝐞 and through the how patient tolerate the boy patient the through body wake up sheet young but young pain pain patch so the patient different below round the so how assess below available oral available IV available sale IV sale IV museum instant delivery. There are overall prognosis. So the the patient the the information data, the clinical data, and patient goals, the values, the cultural norms, and we have to come up with a patient-centered care plan. That is the palliative care, the plan, the care plan are very important. We have a plan. Our family pure every the whole team, we know the plan. So that everybody know what's the next step to do, what's the next step, what's the patient goals, what's your wishes, and how we're going to escalate the treatment. So the planning is very important from the beginning. Now, let's go dive into the symptoms in the dominantly ill patient. Pain are the physical pain in it, the physical pain or control pain the child spiritual care or the anorexia, dyspnea, nausea, vomiting, what are the drug of choice for the dominant delirium through so many they are very distressingly family you to put it now the waku combos so the so many 𝐸𝐴𝐻 on so in family so in as the culturally the religiously plus clinically this is something we can control. We can adjust the medication, we can give medication to come and sedate them. So there are things we can do to relieve this the terminal delirium. Then fatigue, let's start with the pain. So pain is a multi-dimensional experience. So it's very personal. The best example, palliative care pain in the beyond. So pain has a meaning. The Western medicine, to always talk about pain and suffering, pain and suffering as this is not the same. The pain is a more of a subjective. The suffering is objective. The best example, my family now, so yeah, patient patient treatment. How about the delivery, labor pain, remember? The labor pain on the everybody forgot. If you ask them, do you want to have another child? Of course, they will do it in another year. Even some people with intendants, because that bring a lot of meanings. They bring a lot of meanings of pain, and they forgot the pain right away. Nobody talk about, oh my God, the pain is so bad, I don't want to have another child. On the other hand, the cancer pain, even though this is mild pain in the beginning of the pain, this is horrible. They say, oh, this is the cancer is hurting me. No, they're very personal. So we're now sure the suffering over the objectively shooting the example the pain over objectively shooting the example the cancer now when the diamond Nara shoot it's not Nara shoot. That's not So Damology, meditation is this is just an example. Pain and suffering. Pain over suffering is less. So the nara so how you another psychological pain. So Ponareha Ponala, Go Tanara and Pare, the cancer just like that, so like that, so they had a tattoo of Pona. Total pain they have concept with these doctors, history, sounders, and the so the physical pain, physical nara, the man, there's a meaning, psychological meaning is bad, so even the pain depression when I pain of oh, Namadina, yeah, I dropped out of my doctor like I'm a young so are you put depression, anxiety, now, my the psychological, the pain are there, when I spiritual pain, it's not just a religion. How the church are there, Loba Dola Moy in our life, they can each ama, oh my, not me up the market, Nausea, not me out and a tip for you get the boy. Hey, Tago Tanami and Comima go, no chamber, no one between the Mechano go the Loba in line something. Met go and take an ichama. Go market, little too suffering, they on union to the Roma. This is a spiritual, pain. So the high that patient on it, on it, they made pain say love with it through the spiritual, cause of tremalone and so yeah. The actually suffering at the moment, on it, Jama hope. Tamalo general Dario, social pain, Uma pain, social pain. Patient member, do us with tower the breast cancer, tower single mom, clear, Java send it. So a single mom, the Yagadu get wire to delta the Kalin, the meaning would look junior. I'm a Kamatena, generally a cam account to grant the metastatic breast cancer. So Silma do on it, basically below the IV, without it, she didn't stop. To get into a major I cannot die because who's going to look after my, the two children. So I do my say I'm in the machine. So not the one calculated to Gina. That is a social pay. So Damano the palliative care or team approach and the moral social worker in a bit of mutable contact with make sure that somebody will, guarantee, the planet, take a look at so okay, we will say Chababi, so they have new Jama, they can let go. So that is knowledgeable. So paying the total the concept of total pain are very important. Just don't just the pain medicated patient and pain. We have to accept their psychological pain. spiritual pain and social pain, no? So, one concept, physical pain. Let's go back to physical pain. So we all must die, but I can save him from days of torture. This is what I feel is my great and ever new privilege. So, this is our privilege, right? Nobody else can do this. So, pain is a terrible lot of mankind than the death itself. Actually, death is a very peaceful, right? Very peaceful. The pain is a torture, in the transition. This is something we can, help the transition. Religious in this way. So pain definition and pathophysiology. So sensory and emotional experience associated with the tissue damage. General pathological, tissue damage, nerve, the cerebral cortex, pain, pain in the message. The nociceptive pain, visual pain, somatic pain, the nerve pain is neuropathic pain, the nerve injury, nerve erosion, pain. Bone erosion, bone pain. Very important, but the pain medication treated. Are we dealing with the neuropathic pain? So, gabapentin, so in the neuropathic pain account. Bone pain, the opioids, plus, steroid, bone pain. So, how do we know bone pain? The X-ray, bone erosion, not pain, the burning pain, collapse and stalking pain, and I'm general. So acute and escalated pain is emergency. That's why generally we need this is emergency. We need to control, as soon as possible. General control poor quality of life. But in general, we are not usually doing a good job. But because a patient morphine, no, patient to get physical pain, patient will explain no. Don't worry about addiction. The pain, the say we not encourage we are not comfortable prescribing adequate dosage. The morphine pill the professor, medical school, the professor, both are professor, the pediatrics, the surgery. So I do spouse card, they can need morphine, serum morphine treated. Everybody is, hesitant to give a, a good, full dose. Morphine pill, so if you know how much to give, and if you, titrate, gradually, that, there's a very little chance of respiratory depression and, death. So in the morphine young people who thought the fit on so they had, the panani patas they had jump. I mean, no, the Luna way now that I would, say a morphine period. Even the no cook can she say now she because they didn't be the way now that down so they had a beer so yeah. There's no panani pata can so the man. The home out the post so Luna pain and matata, Kubagale, was a copia had about material. That's worse than, do not get, pain medication at all. So let's so general WHO approach very basic, but the visa pijama, the general basic my pain so generally non-opioid moderate pain so weak opioid, plus the adjuvant severe pain so general recommendation or the strong opioid, and non-opioid about the steroid the adjuvant. So this is a general approach that the WHO are already recommended. So that's another I know morphine shaman or the plus severe pain by all means use the opioid morphine. So general being morphine down type we discuss it. So my pain so the aspirin, down, the acetaminophen, the one of Tylenol problem, the paracetamol, the ibuprofen, my pain so moderate pain so the hydrocodone derivatives or 𝐤𝐞𝐜𝐬𝐿 hydrocodone but the derivatives now Tylenol with codeine. The audience of them, the body, home body, Tylenol with codeine. The hydrocodone, the whole oxycodone is better than Tylenol with codeine. So if you have a both available, I would the oxycodone and hydrocodone less side effect. It can more potent. So the pain control majority. Tylenol number 3 will still be the side effect in pain control the material. But if you have a both option, then use either hydrocodone or oxycodone, which has more potent and less side effect. So usually I go another 4 to 6 hours. They don't usually last more than 6 hours. But not the better than bit Tylenol and Tylenol overdose 3 times. I think the Tylenol total dose are 3 to 4 grams. The Tylenol overdose, liver damage and fulminant liver failure and Tylenol generally total dosage, the 12 tablets at severe pains are where you only have one option, morphine. So I'm on the oral, the liquid, the pill, tablet injection, subcutaneous. So patient, subcutaneous IV drip so liquid, the same you are the liquid concentrate, oral concentrate, 20 milligram ml, now IV general intermediate and diarrhea shama, but the or morph to MS content, the morphine MS content in the now hydromorphone, so what are more potent? The morphine is 5 times, just to mention in case they look hydromorphone, more potent. So that opioid has a lot of people, not opioid, child, she was morphine of 𝐷𝐿 child, so morphine was 𝐷𝐿 pure. That's what about it. That just information, morphine and Shanghai and block qualities are general change. So you got to 8 slides, morphine and hydrocodone, to do potency in the air. Oxycodone 1.5:1 ratio. So I don't potent. Look at this. Korea potency. Korea 180 milligram morphine 30 milligrams. You have to give high dose to get the same equivalent, analgesic effect. But on the other hand, a lot of side effects like constipation, nausea. The codeine, morphine also codeine codeine derivatives. Codeine morphine is forget about codeine because codeine have more side effects and less potent. Hydromorphone are generally very severe pain, not controlled by morphine, so hydromorphone will drama. But I mean, the morphine will control the hydromorphone. The best card of the 𝐦𝐞𝐈, so a lot of no one, masala and methanol, so a lot of smooth control. So the one best card 72 hours kind of so the don't have to call lay the best you lay the fundamental best card so don't jump the Bazaka pays museum low. Morphine and other general advantage to the liquid form jar through patient museum general the shower layer the Bazan lima the syringe in it tell it is a daughter the mucosa and absorb the water to jamolo. General the morphine are general number 1 choice for not to liquid function of the blue vision museum to absorb the water, genesis science, they left that I think the available chemical tenable, morphine let's start with a case, but the case is a little more exciting. 75-year-old woman has ovarian cancer with metastasis to liver and peritoneum. Abdominal pain had been well controlled with sustained release morphine sulfate, 200 milligram orally twice daily. But she now reports severe pain once every 3 days. Which of the following is the most appropriate analgesia for the breakthrough pain? Morphine sulfate, that's short, immediate acting, 60 milligram pain, 100 milligram pain, 200 milligram, pain, propoxyphene, Davon, the more pentazocine and intramuscular doma. So go most of it, well, polo yam.
Yeah, well, Dialia Polo Mela, the Sa Yamian Ludua, Jonga Lamakan. Sorry, Vasia. The chat don't move on Polo Tavares. Okay, sorry, was
check out the general, audience would check, not to be Java. Most of it, they twice up by Shim.
Yeah, well, Chaposcani, okay, Vasia.
So, Kumoza responding to chapter 1.
Mapija, Sinani.
So, okay, other than
Mama,
the case are Nausea water. So, a tiara general 60 milligram or not tiara, but pain management, we have a science, the young line, overdose him out there. So, no formula Shiva, the breakthrough will be let's go over it. So breakthrough doses is 15% of the total daily dose. Somehow 50% of the Q4 or Q6. So let's universal rule in the 15% of the total daily dose. So let's go back to the previous case. So blue 12 oh, sorry. Advanced the thing. Sorry, I'm going to case with the okay. Imagine 200 milligram, right? Twice daily is a long acting. So our total daily dose are 400 milligram, right? 400 milligram, 15%, so 60 milligram. So the correct answer is 60 milligram, right? So 15% of the total daily dose. So this is a very important formula. But look at the dose is 5 to 15% of total daily dose. So general the patient and the morphine and the fentanyl patch and so we have to convert everything back to the morphine equivalent dose. And I'm 50% of Pian 50% Pian the breakthrough dose, the 15% one, the one dose also in period case. So in 400 milligram, 15%, 60 milligram. So the order should be 60 milligram every 4 to 6 hours as needed. So and again, this is a science one, the breakthrough dosage as needed. So oral, oral where the general morphine the mountains, slide comment and comment side effect general. So common side effects are constipation, nausea, vomiting, dry mouth, sedation, and sweating. So common side effects. So that anticipate even prescribe some the constipations. We need to prescribe the laxative at the same time. You do morphine to do. Don't wait until patient are constipated because they're going to get constipated for sure. So don't wait until patient started to have a bloating and nausea and vomiting. That's little too late. So uncommon factor delirium uncontrolled pain is reason for delirium too. So the pruritus the morphine do not stop. Isn't because that can cause a histamine release. It's not like an allergic reaction. Yeah, how do we know this is the pruritus, just pruritus or allergic reaction? Allergic reaction is usually a drug rash in it, the shortness of breath, the child sweating in there to get full-blown allergic reaction. Just yara the is a known side effect. So that that they will at the time antihistamine and be like 1 or 2 doses. It should resolve on its own. Uncommon respiratory depression, very uncommon. We will discuss more about the respiratory depression. Let's start with the constipation. all the opioids can cause constipation. But people say that the opioids are the mu receptor, the 𝐺 mu receptor, aggressive. The bowel, the intestinal movement will slow down. Decrease the GI motility, increase the sphincter tone, then increasing the fluid resorption and decreasing GI secretion. That's why opioids are known to cause constipation. When you are writing prescription, or the order for morphine, you need to order the laxative at the same time. That's easier to prevent than treat. The constipation patient nausea, vomiting. So I don't know when the enema tolerance never develops. So as long as they are using the morphine, they must use the SANA. So the message is very important. Tolerance never develops. So they always need to use it together. So the two patients the constipation or treatment very important. The start the accident stimulant laxative. I SANA usually recommend 2 tablets, 8.6 milligrams. 2 tablets, at the bedtime, so to have the daily bowel movement. That was SANA and the 2012 year and usually the fiber in the metamucil or the constipation treatment fiber don't for soon and this patient fiber down just fiber SANA nausea vomiting. So usually I start with the opioid, but tolerance develops within days. So I take my the compensine, chlorpromazine, and I'm really be like through more the morphine, the chlorpromazine in a 12 bars. So you may have one hour pure be a hajai. Now by giant, but I'm a top end, Jesus, that's okay. So tolerance develops within days. The time the Piozamlo, the show Sabi Nausea, okay, Nausea, Darlene, like the compensine, the anti-emetics one, the compensine, the severe health or general first line and the and so the two patients, the cancer pain, morphine, high dose PR, nausea, health all in a health or compensine sign, strong chip, strong chip that made a side effect for Jamlo, held on in the second line, severe nausea, vomiting, my health. First line of the compensine, the chlorpromazine, the morphine mechanism, nausea mechanism, the body, the chemo, trigger, triggers the one, CTZ, the morphine. Now, the opioid molecules, they sense it. So they know, brain, oh, this is a foreign, chemicals. Oh, we don't want it. So the body, the brain is the stomach, sorry, the signal for our. The nausea, vomiting, that means they get used to it. Say a woman down in the end down there, the CTZ, tolerant, insensitive to they will be okay about it. Okay, the chemicals through exposure, they, the patient can tolerate. Now to put Matata, these are the anti-nausea, alternate morphine news, the oxycodone, jumpy, hydromorphone, the nausea, vomiting, and treatment. Let's do case number 2. 83-year-old man is brought to the emergency department because he has had intractable nausea and vomiting for 36 hours. Again, intractable, so very continuous, very frequent, continuous, nausea and vomiting. He has had poor oral intake over the last week. He has a bowel movement every few days. He has now had constipation, diarrhea, urinary symptoms, fever, or chills. History includes Parkinson's disease, mild cognitive impairment, stage 4 colon cancer. There has been no recent change in medication. On the exam, the abdomen is mildly distended with positive bowel sounds and diffuse tenderness to palpation in the bilateral upper quadrant. CAT scan of the abdomen show increased hepatic and peritoneal metastases compared with imaging performed 3 months ago. Intravenous hydration is started. So basically, patient had nausea, intractable nausea and vomiting. Underlying cause are the intra-abdominal spread of the colon cancer. The liver and the peritoneal mass, causing that intractable nausea, vomiting. So which one of the following is the best treatment option for his nausea? So oh sorry, here.
Oh, fully release လုပ်လိုက်ပါမယ်ဆရာ
So option question which of the following is the best treatment for the nausea?
ဟုတ်ဆရာဖြေနေကြပြီဆရာဟုတ်
Okay, good.
ကျွန်တော်10မိနစ်လောက်ထားလိုက်မယ်နော်ဆရာဟုတ်
Oh, thank you. So the undensed cetron as needed around the clock so yeah, very good. I think it's not round one, the nausea intractable nausea vomiting for 36 hours to give the patient the continuous relief. Actually, the Zofran undensed citron around the clock will be out. Say very IV chance just use the IV IV portion every around the clock be out. The correct answer around the clock.
ဟုတ်ဆရာ result တွေ share ထားပါတယ်ဆရာဟုတ်
Okay, then I'll learn it. So tolerance develops within days. The sedation the sleepy tolerance develops within days. If persistent, the alternate respiratory depression pain is the patient pain the pain breathe usually loss of consciousness the respiratory depression patient go that's still okay. Okay. Respiratory depression. Depression usually depression. This is reduce the opioid dose reduce short naloxone carefully. Pain crisis, but the new receptor blood pain crisis the pay dilute 1/10 of the dose normal saline pay that the morphine and the renal failure kidney shut down the kidney the dilaudid fentanyl and methadone Okay, case number 3. 75-year-old female with pulmonary fibrosis who developed COVID infection present with the increasing shortness of breath. She has been using morphine sulfate or solution for every 4 to 6 hours for 2 months. Because of increased shortness of breath, morphine sulfate was increased and this giving every 2 hours. So nursing staff reported no urine output for 10 hours. Now she started to develop random twitching and jerking of her muscles in extremities. Family also noticed tenderness to touch and movement of her. She then developed delirium or hallucination. So, what is the most appropriate treatment? Because of increased pain, give morphine every hour, on the hour, or decrease dosage of morphine, or change pain management to methadone. Start haloperidol for delirium and hallucination. Start IV hydration. So,
Oh, yeah.
So, yeah, thank you for your answer. The correct answer is actually, nobody pick it. Decrease dosage of morphine actually. The case patient the kidney shut down so 10 hours no urine output. Morphine patient shortness of breath every 2 hours. Dosage of that frequency morphine but neurotoxicity morphine one of the known side effects neuroexcitatory effect ပေါ့ neuroexcitatory ဘာဖြစ်လဲဆိုတော့ muscle twitching ရဲ့ jerk ဖြစ်ရတယ် plus ဒီဘယ်လိုပေါ့ဒီ hyperalgesia so very tender to touch ဒါမှမဟုတ် pain နဲ့တော့မဟုတ်ဘူး pain နဲ့ဆိုတော့ဒီ facial grimace ဆိုတာဖြစ်လာတယ်ဆိုတော့ထိတော့မှဆိုတော့နားလာဆိုတော့ very sensitive ဆိုတော့ hyperalgesia plus muscle twitch and we need to watch out for muscle twitch and muscle jerking movement and muscle twitch and hyperalgesia we need to suspect that neuroexcitatory effect of morphine usually အစုဖြင့်ဒီ kidney urine output လည်းမရှိတော့ဖြစ်သွားပြီဆိုရင်တော့အဲ့ချိန်မှာ first step ကတော့ we need to decrease the dosage ပေါ့လေနောက်တစ်ခုမှအဲ့ဒါမှမတက်တာကို continue ဖြစ်တယ်ဆိုတော့ another option က methadone ပေါ့ဒါပေမဲ့ option ဒီချိန်မှာဒီ patient ကိုကြည့်မယ်ဆိုရင် pulmonary fibrosis ဆိုတော့ covid ရဲ့ခါကျတော့ဒီ morphine ရဲ့အဓိကရည်ရွယ်ချက်ကဆို shortness of breath ကိုသူကအဓိကသုံးနေတယ်ဆိုတော့ methadone က chain effect ကမလာဘူးပြောင်းတဲ့ခါကျရင်ဆိုတော့ patient ကအခုကပိုပြီးမောလာတယ်ချင်းမြင် pulmonary fibrosis နဲ့အခုက covid လည်းရှိတယ်ကြောင့်မလို့သူကဒီ morphine ရဲ့ beauty of the morphine အဲ့ချိန်မှာမလဲဆိုတော့ဒီ sense of the respiratory distress ပေါ့နော်ဒီ shortness of breath ကိုသူကအဲ့ဒီ feeling of short of breath ကိုသူကပြန်ပြီးတော့ threshold ကိုသူကမြင့်ပေးတဲ့သဘောပဲဆိုတော့ relief of the shortness of breath ပေါ့နော်ဒါမှမလို့ morphine ကိုလုံးဝမရက်တင်ဘူးတတ်နိုင်ရင်တော့ဒါမှမလို့ဒီသူ dose ပဲ short လိုက်ပါသူတို့ monitor ဒါမှမရဘူးဆိုတော့ methadone တော့ပိုင်းပြောင်းပေါ့ဘာလို့ kidney ကအလုပ်မလုပ်တော့ဘူးဆိုဒါပေမဲ့ morphine give morphine ထပ်ပေးခြင်းအပြင်ပိညာပူနာလို့ပဲဆိုရင် morphine ထပ်ပေးပိုဆိုးပဲရှိတယ်ဆိုတော့ haloperidol ကတော့ terminal delirium မှာဆိုတော့သုံးလို့ရပါတယ်ဒါပေမဲ့ဒီလိုအားပြီးဖြစ်ခါစားမှာ haloperidol ပေးရင်ပိုတော့မှဒီ muscle twitch ရောပိုတော့မှဆိုးနိုင်သေးတယ်ပေါ့နော်ဒါမှမသုံးအောင် IV hydration ကပေးလို့ရတယ်ဒီ terminally ill patient မှာ IV ထုတ်ရတယ်ဆိုရဲကတော့ထပ်ပြီးတော့ more pain and more suffering ဒါမှမဟုတ် it's not the right answer now okay bone pain ကျွန်တော်ပြောလို့ပေါ့ bone pain ဆိုရင်တော့ကျွန်တော်ဒီ steroid ပေးလို့ရတယ် NSAID သုံးလို့ရတယ် radiation သုံးလို့ရတယ် neuropathic pain ဆိုရင်တော့ကျွန်တော်ဒီ steroid သုံးလို့ရတယ် now ဒီ tricyclic antidepressant like desipramine တို့ nortriptyline တို့သုံးလို့ရတယ်ဒီတော့ဒီဒီ antidepressant မှာဆို duloxetine သုံးလို့ရတယ် anticonvulsant မှာဆိုရင် valproic acid valproic products ပေါ့နော်ဒီ sodium valproate တို့ gabapentin တို့ pregabalin တို့ကျွန်တော်သုံးလို့ရပါတယ်visceral pain တို့ bowel obstruction တို့မှာဆိုရင်ကျွန်တော် steroid သုံးလို့ရတယ် octreotide ကျွန်တော် adjuvant နဲ့သုံးပါတယ် non pharmacologic management တော့ဒီလိုကျွန်တော်ကပေါ့ဒီ psychological pain နဲ့ spiritual pain ကိုကျွန်တော် accessible လုပ်ပါတယ်အဲ့ဒါကြောင့်ကျွန်တော် antidepressant နဲ့တွဲရမယ်ဒါမှမဟုတ် counseling ပေါ့နော်ကျွန်တော်ဒီ spiritual pain ဆိုရင်ကျွန်တော်အချိန်မှာကျွန်တော်ဘုန်းကြီးပြင်ရတော့ပေါ့နော်သူရဲ့သူတို့ခွင့်လွှတ်ချင်တာတောင်းပန်နေတဲ့ဟာတွေပြီးတော့သူတို့ရဲ့ဥစ္စာတွေဖြစ်ဖို့အတွက်ငါဘယ်လိုပေါ့ဒီ physical ဒီ bone pain တွေ joint pain တွေကျတော့ physical therapy can help သူတို့ရဲ့ဒီ movement passive movement နဲ့ဒီ physical therapy နဲ့ pain ကိုဒီ blood flow ကောင်းပြီးတော့ of course ကျွန်တော်တို့ပြောပြီးတော့ meditation ကတော့ is the best pain management ပေါ့နော်လုံးနိုင်တယ်ဆိုရင်တော့ဘာဖြစ်လို့ဆိုတော့ no side effects no is free but also ဒါပေမဲ့အခက်ဆုံးပေါ့နော်ဘာလို့ဒါsorry ဒီ meditation မှာပုံမှန်လုပ်ထားမှာပဲတကယ်ဝေဒနာကြုံတဲ့အခါကျရင်ဘယ်လိုရင်ဆိုင်ရမလဲဆိုတာဖြစ်တာပေါ့ဒါမှမဟုတ်လည်းကျွန်တော်ဒီ data တွေမှာဆိုကျွန်တော်ဖုန်းကြီးတွေအမြဲပြောရမှာဒီနာဝေဒနာကိုမကြောက်နဲ့ဝေဒနာကိုချိန်မှဖြစ်တာမှဒါမှမဟုတ်တို့တွေဗမာကျွန်တော်ငယ်တော့ကြားဘူးလားမနာခင်ကနာထားကြနာရတတ်တာဆိုတကယ်တေကန်ဒီမှာဒီယောဂကြောင့်မလို့နာတဲ့ဟာရမ်းဆိုးပါဒါမှမဟုတ်ဒီကျွန်တော်တရားထိုင်တဲ့အချိန်မှာတနာရီနဲ့နာတဲ့ဝေဒနာဘာမှမဟုတ်ပါဘူးပြန်ပြောမယ်ဆိုတော့ဒါမှမဟုတ်ဒီ meditation လုပ်နိုင်မယ်ဆိုတော့ this is the best pain management okay last case pancreatic cancer who recently diagnosed with COVID infection had worsening shortness of breath and over the last few days he has spent most of the time in bed typically asleep with minimal oral intake he has acquired increased doses of sublingual morphine to relieve his dyspnea and often difficulty to arouse. Shortness of breath improved with the initiation of sublingual morphine 2 milligrams every 2 hours around the clock. Over the next few days, he became unresponsive and developed increased respiratory secretion. So these are the options, no? Oh. So ကျွန်တော်ချိန်က running late ဆိုတော့ကျွန်တော်မြန်မြန်အဖြေပြောလိုက်ပါမယ် so ဒီပါတော့ကျွန်တော်ဒီ secretion ကိုကြားဖို့ဆိုရင်တော့ဒီ atropine 1% eye drop ဒါလည်းကိုဝယ်လို့ရပါတယ်ဆိုတော့ 2 drops sublingual every 2 hours ပေးလို့ရပါတယ် things to remember, general pain management. So constant pain needs constant pain medicine. Pain meds and bowel meds should go together. Resolution depression does not happen to an awake and uncomfortable patient. Pain is most people fear about death. Pain is most important. So I'm not about pain, anorexia, dyspnea, nausea, vomiting. Delirium, drug or drugs are Haldol. Haldol don't medical. Patient, respiratory, distress, shortness of breath, Valium, the benzodiazepine, Valium or drug, diazepam. Diazepam held off usually medicine, combinations of held off is the drug of choice. Fatigue, usually are the difficult to treat. There are psychostimulant, very severe fatigue, psychostimulant, amphetamine or pseudoamphetamine to treat. So that's why cultural and spiritual consideration. You need to get to know the patient through the cultural, religious background. Even Christian, through faith and through we need to have a Christian, call through help through a desire for aggressive care. We need to do that. So we need to understand their background more. The pain we are pain down or more ordered so they have the family has So this is the last slide, but we have the question. So life is pleasant, death is peaceful. It's a transition that troublesome. So that's why the palliative care, comes in. If you are, good with palliative care and focus on palliative care, we can, make a difference. Life usually, life is pleasant, death is peaceful. But this is in our hand, whether the transition is, smooth and peaceful or troublesome. So this is my last slide, and open for questions. Sorry for the lecture already. We're 10 minutes behind. But make only
okay, sir. Thank you very much for inputs, and it's very interesting. Digaro kuna sir the general alunga the yamibo no do leve the matigan sajama kanzare pinga intolerable. Now the chojaro the mago long chop piroma matigine. Focurine dune di Silico. Jarema general who Samia so Cachero bed Sinti general Lunana and Luna Swimirigo, pure Messureke Saviria, general Nizin Juntuere Pale Pibare. General Dimaga, general to the pin, general chin community dema solution, but Pietana she lesson. Yoga go Muria teaching. Luna Roma Piovane, Chamaru Piova. So that Pietana Togo Chimava. Amaro tu Raikaro, Duna Vetian, Duna Tibima, Muria Tibu, Sura Mugo Hobi Lunabo, no? Era Luna Chanabra, Luna Mount Dematare, Durado Sao Broma, Muria Alungu, Piobia Vivi, General Lunaro, Tiro, and Pure Savas, and Lunaro Matide. And Uzureka Zero, Diniarima, Puna Pure, General Luna Gubelu approach Lubu Piomane. The two lunas are imitant that is she. Piova, General Jama, Tiramachababu, Dodo, some teaching him, no? Era Mujara, Piora, Lenway. The two Jarone, Tigani, Toma, Mujigu, Tuadumia, Sureha, Liria, Shini. Ersin Jara at 𝐾𝐿𝐬𝐿 in Roma, Syria, Jamus, Sonone, Shalluchin people. Ero, Erinari, Muma, General Dimaro. Counselor, Ludo, Shida, no counselor, good, Cobiroma, too good. Nitema, oh, gonna say a pure whole pain, no, Apuno, not a social, spiritual, Apuno, and a consider Casera to approach Lugro or nobody, number of spiritual marats and not Ponji Lenare, Kriani solution, Pastari, Lavra, Stutam Biri, Sadakin Lubari, no, and so the Haga, General. Too good to a niece and to a machine and Petana Pide goes and in a Kulu. A PBs on Piopia Pira, Jesutimale, not sad, so not pain relief dema. So not dema more dimorphine. heroin ပေါ့နော်ဆရာပြောတဲ့ထဲမှာမပါတာကိုကျွန်တော်တွေ့ရပါတယ်ဒီမှာကျတော့လည်းကျွန်တော် morphine တွေနဲ့ဝယ်တာအင်တန်ခက်တယ်အင်တန်ခက်တဲ့ခါကျတော့ heroin ကတူတိတ်နဲ့သူတို့သုံးတဲ့လူတွေရှိတော့အဲ့ဒီမှာသူတို့ community ထဲမှာ available ဖြစ်တဲ့ခါကျတော့သူတို့လာပြီးတော့မေးကြတယ်ကျွန်တော်တို့ morphine နဲ့ကျွန်တော် supply မလုပ်နိုင်ဘူး supply လုပ်မယ်ဆိုရင်ကျွန်တော်တို့တေချာကို register လုပ်ပြီးတော့လုပ်ရတယ်ကျွန်တော်မရှိတဲ့ခါကျတော့သူတို့ကအဲ့ဒါကိုသုံးလို့ရမလားလို့ပြောကြတယ်ကျွန်တော်တို့ကတော့ကျွန်တော်တို့ advice ပေးတယ်လို့မပြောနဲ့လူနာအတွက်ဒီနာရာတက်တာပြီးဆိုရင်တော်ပြီလို့ခင်ဗျားတို့သုံးကျင်တာသုံးတော့ဆိုအဲ့လိုပြောနေရှိတယ်အဲ့ဒါကိုဆရာအဲ့ဒီမှာဟောသူတို့သုံးနေရှိသလားပေါ့ဆိုတော့မိကွန်းတစ်ခု thank you sir over to you
မပြော the heroin ပြောရတာ
heroin number 4လေ
oh okay got it ဟုတ်ပြီ
diamorphine ဟုတ်ကဲ့
Yeah,ကျွန်တော်အဲ့ခါအဲ့ကြရင်တော့ကျွန်တော်ရဲ့စပြတော့ yeah ဒီလိုဆရာတွေ့ကြုံရအောင်ဒီအဲ့ heroin သုံးတဲ့ခါကျတော့ပိန်းသက်တာလားကျွန်တော်ဒီမှာကျွန်တော် illegal ဖြစ်နေတာကျွန်တော်အတွေ့အကြုံရှိတယ် heroin ဆရာတန်းအတွေ့အကြုံကြတော့သက်တာလားသူတို့ပိန်းရသူတို့သုံးတဲ့ခါကျတော့ဆရာတန်းမျိုးလောက်ထား
ဈေးရရှိတဲ့ခါကျတော့ကျွန်တော်တို့ဒီမှာတော့ကျွန်တော်စေးရုံမှာတော့မသုံးနိုင်သေးဘူးဆရာ Okay thank you over to you
Yeah ဆိုတော့Yeah,အဲ့လိုပေါ့ကျွန်တော်လည်းဒီမှာတွေ့ကြတော့မရှိဒါပေမဲ့ပေါ့ heroin ကတော့တကယ်တမ်း pain သက်သာမယ်ဆိုရင်ပေါ့နော်အဲ့ဒါအဲ့မှာသုံးရတော့မှာပဲကျွန်တော်ပြောတာဒီအဲ့ပေါ့ဒီ transition မှာတော့အရင်ရေးကြည့်နေဒီနာဝေနာမခံစားဖို့ရေးကြည့်ရဆိုရင်တော့ဒါမှမဟုတ် another say ပေါ့နော်ကျွန်တော်မပြောရမပါတာဒီ marijuana ဆေးကြောက်ပေါ့နော် marijuana ကျွန်တော်တို့ဒီမှာတရားဝင်ကျွန်တော်တို့ဒီ palliative မှာတရားဝင်သုံးခွင့်မရဘူးဒါပေမဲ့ကျွန်တော်တော့ patient ကတော့စားတော့ပြတ်တယ် nausea နဲ့ရလာတယ်စားတော့မစားနိုင်ဘူးဥစားဖြစ်တယ်ဆိုရင်အဲ့မှာကျရင်ဆေးကြောက်ကanother medical marijuana ပေါ့ဒါပေမဲ့လည်းဆရာတန်းတို့တကယ်လို့ you can recommend and you can even try ပေါ့နော်ဆေးကြောက်ဝယ်လို့ရတယ်သုံးလို့ရတယ်ဆိုရင်တော့ဒီက nausea ကိုစားစီနေစားတော့ပို့ပြီးစားလို့ကောင်းတယ်ဆိုတော့တခြားဈေးကြီးပေးတဲ့ဆေးကျွန်တော်ဒီမှာဒီ FDA approved appetite stimulant တွေရှိတာပဲဒါပေမဲ့သူကတကယ်တမ်းမကောင်းဘူးလေဆိုတော့ကျွန်တော်ဒီကျွန်တော်ယူဆရဒီ marijuana ပေါ့ဒီဆေးကြောက်စာရမယ်ဆိုရင်လည်း yeah ဆေးကြောက် is good for nausea ဆေးကြောက် is good for appetite evenဆေးကြောက်ကတော့ it's a good antidepressant euphoria ထိုင်လို့ပိုကောင်းတယ် so အဲ့ခါကျရင်တော့လေတကယ်လည်း patient လည်းတော်တော်ဥစားဖြစ်နေပြီဆိုရင်တော့လည်းပေးစင်တာပဲလေကျွန်တော်မြည်စားတော့ so thank you for sharing ဆရာတိုင်းကျွန်တော်ဒီမှာအဲ့ချင်းမှာပါတယ်ရမှန်းကျွန်တော်မသိဘူးဆိုတော့ yeah thank you for sharing any question so အဲ့ဆိုရင်ဒီစရာမရှိတော့ဆိုတော့ကျွန်တော်တို့ဒီမှာရက်လိုက်ကြတာပေါ့ so ကျေးဇူး follow
ဟုတ်ကဲ့ပါဆရာ
thank you everyone
ဟုတ်ကျေးဇူးပါဆရာ
အများကြီးတင်ပါတယ်ဆရာဟုတ်